Awesome. Well, welcome everyone to our June Sunday Conversations presented by the Massachusetts ME/CFS and FM Association, otherwise known as MassME. We're really excited to have all of you and thank you for coming. I'd like to extend a special welcome to our MassME members today. Your membership makes it possible for the organization to host and sustain the Sunday Conversations, support groups, patient services, and more. If you'd like to learn more about how your membership helps the organization or to become a member, please visit our website at massmecfs.org/join. Today, we're honored to have three speakers from the Mass Pain Initiative, otherwise known as MassPI, with us today, and their talk is Improving Pain Care Through Education and Policy. So the Mass Pain Initiative began in Boston in 1966 when there were 10 other pain initiatives across the country, but the MassPI has preserved and is a nonprofit with the mission to improve the lives of people suffering from pain with a focus on knowledge, education, and policy. So it's an honor to introduce our three panelists. Ms. Cindy Steinberg is the Director of Policy and Advocacy. Ms. Steinberg has been a consultant for the NIH and has even testified for the U.S. Senate Help Committee on managing pain during the opioid crisis. She herself is also a chronic pain patient. Jackie Nathan is a board-certified advanced practice registered nurse. Nurse Jackie is a pain management specialist and has co-developed a novel and highly effective approach on pain, neuroscience education, and yoga. Dr. Michele Matthews is a board-certified pharmacist with a pharmacotherapy specialty certification, and Dr. Matthews is a professor at the Massachusetts College of Pharmacy and Health Science. Dr. Matthews is also an expert on pain and has published on the subject. So this is just a brief summary that gives the surface for all of our three speakers, and their full bios will be available on our website after the talk. So we welcome our panelists from the MassPI, and thank you for presenting with us today. We're going to begin with Miss Cindy Steinberg. So Cindy, the floor is yours.
Thank you very much. Nice to meet everyone. And it was interesting to see how so many of you live with pain. I live with pain myself. I had a very serious accident about 20 years ago when I was crushed, and I simply opened up a file drawer, and unbeknownst to me, moving men had stacked cubicle walls behind it, and I didn't know they were there. And I opened the drawer, and then I was crushed underneath the cabinet and all the walls, and it basically tore nerves and ligaments in my thoracic spine and left me with sort of a burning, gnawing pain every time I'm upright. Even though that was more than 20 years ago, I still have pain every day. And one of the ways I manage it is to manage the amount of time upright. So when I originally started with pain, I started looking for help while I was managing a pretty busy life. I had a career, managed like 40 people, and I had a baby and was married and traveled. And I tried various kinds of things. First, I wanted to know if surgery was an option, and it really wasn't. So I went to pain clinics and tried nerve blocks and injections of all kinds. And that didn't really do much for me. I tried some alternative things. I tried physical therapy and occupational therapy, but the pain was still there, and it would get worse the longer I was upright, and even getting into muscle spasms, really badly muscle spasms, if I was upright longer than an hour. So during this journey, which took me 5 years to find help, I was often treated like I was making this up, in a dismissive manner. As somebody that worked, 80 hours a week in startup companies, I wouldn't waste my time just making this up. It was very demeaning. Other doctors were nice and tried to help me, but if they couldn't, then they just said, go on to the next thing, or I can't really help you. And I called it sort of the roller coaster of chronic pain treatment. You get your hopes up that the next treatment you're going to try is going to be great. I'll try acupuncture, that's going to help. You invest money and energy and time doing it. You try to stay hopeful, and then you try it for a month or 2 months, only to have your hopes dashed. And as a result of all this, oops,
Sorry, that was
no problem. As a result of I'll do it now, one slide before. Okay, great. as a result of this, I ultimately decided to start a support group and hung a sign up at the library because I didn't know that people could be in pain 24/7. And people just started showing up. And at the time, I lived in Arlington, Massachusetts, and we met at the library. And the first month, a woman with yeah, degenerative disc disease showed up, and a guy with thoracic outlet syndrome or carpal tunnel. And then they came back the next month, and somebody came who had migraine headaches every day as a result of chemotherapy, and then people with neuropathy. And then more and more people started coming. And I continued to run the group. It has now been 24 years, and I still run my group. It's kind of similar to this group in many ways. People, we used to meet in person, but now we meet on Zoom. And I even have noticed that some people on this call right now are members of my other group, my pain group. So anyone is welcome, and I'll tell you more about that. But what I noticed is that everyone who came to my group, regardless of what type of pain they had seen multiple practitioners, had been on a journey like I had, looking for help. And I started wondering, what is going on here? There's so many people living with pain. I didn't know this was the case. People with chronic pain 24/7. So I started doing some research and looked at some of the root causes. These are just some of them. There are more even, but I realized when I looked at the NIH budget, which NIH pays for most of the basic research in this country, that less than 2% of their budget was spent on pain research, even though pain was the #1 reason why people go to their doctors. Also, we still do not understand, we didn't then, 20 some years ago, and we still do not now understand the basic mechanism of pain in the human body. There just was not enough research done to really understand it. We do know from neuroscience now that pain can become its own disease, a disease of the nervous system and brain, and therefore isn't really visible on X-rays and standard radiology. There's a lack of specialized physicians, so less than 1% of doctors are specialized in pain management. Also, doctors get very little education on pain, even though it's the #1 reason, as I mentioned, people go to the doctor, and the #1 cause of disability. So the latest research that I saw was approximately 11 hours they get in US medical schools. That is the least of any developed nation. Just by comparison, veterinarians get 87 hours. So I often say your pet is getting better pain management than people are. And as I experience and many others, there's a real dearth of effective treatments for pain. So I am one of those people that decides that if I don't like something, it's important to try to do everything I can to change it, instead of just lamenting about the problem. So I decided I was going to work at the policy level. I loved my group, and I still do it, and want to help people on an individual level. But I felt that policy was the way to really influence a lot more in pain care. And I've devoted my life's work to that. I have been involved in pain advocacy and policy, both at the state level and the federal level, since 2009. So in 2008, I joined MassPI, and then I took over the policy council at MassPI. And I want to give you some examples of the kinds of things that we've been able to do at MassPI and the Policy Council. And that is, we've engaged in a lot of state work. So I started to realize there's a lot that happens at the state level that affects the care of people living with pain, and that people with pain weren't there to talk about it and to really educate lawmakers about the problem. So one of the first things I did in 2009 was to draft a bill requiring doctors in Massachusetts to take 3 hours of continuing education in pain management. And I worked with a lawmaker there who didn't know what to connect it to. And I said, connect it to their professional license. And so in order to get your license in Massachusetts every 2 years, you need to show that you've taken 3 hours in pain management education. And we got that passed in 2010. I worked on a number of different pieces of legislation up until 2015, and Governor Baker was taking office, and he said one of his first priorities was to do more about the opioid crisis. And ultimately, I got appointed to his working group. I was the only person representing pain, and wanted to be sure that none of the recommendations that we came out with, and there were 65 recommendations, would harm the care of people living with pain. Went on to work on a number of different things. One of the big bills that we managed to get a number of pain provisions in was the CARE Act in Massachusetts, which was signed by the governor in 2018. We got a number of different pain provisions in there, but one of them that I have continued to work on is the requirement that payers, that is insurers, public and private in Massachusetts, have to cover a, quote, broad spectrum of pain management services. And the Division of Insurance was told to write regulations on that. I work with them, and their regulations say that that essentially all the payers in Massachusetts have to have pain management plans, and they need to cover at least 2 medications and 3 non-pharmacological therapies. It went into effect in 2020. So as a result, for example, Blue Cross Blue Shield now covers acupuncture. Plans can choose what they want to cover. Some of them might cover mindfulness-based stress reduction or chiropractic treatments, but they do need to cover non-pharma treatments as well. And then there's something called the MCAS program that we got in that bill, and it's a law now. And that is, many doctors were dropping people with pain, forced tapering people off of opioid medications that may have been helping people with pain. We heard from a lot of people that were negatively impacted. And so one of the things I wanted to do was get doctors to keep their pain patients. And when they don't get training, they don't know what to do for them. And so the state is now running a program of pain specialists that are consult for free. That is, the state pays for these pain specialists to consult with PCPs. It's called the MCAS program. Then I went on to do federal policy. MassPI is an all-volunteer organization, and I worked doing all this policy work until 2013, when the U.S. Pain Foundation asked me to come over and take over their policy, both federal and state policy. And so I now direct policy for U.S. Pain for the past decade, both at the federal level and the state level. And these are just 2 examples of something I've worked on at the federal level. One is the Pain Management Best Practices Task Force, which was a task force that was congressionally mandated of pain experts to recommend what the best treatment is for pain now. And our recommendation was that it's individualized, multidisciplinary, and that combining a number of different treatments is really the best and most effective way to treat pain now, that there's no magic bullet, and people need to combine a number of different things. And if each thing takes down your pain another 10%, and if you get, let's say, a 50% reduction in pain, that might make the difference between being able to work or not, or just have any quality of life. And then another bill I worked on was a federal bill. Most recently, this was a bill that I interested Senator Casey's office in. It's called Advancing Research for Chronic Pain. It is in Congress now, and it directs the CDC to analyze and report on population health data and cost information on pain, so we understand the scope of the problem and can do more for it. So that is just a summary of some of the work I've done. And there are many opportunities to participate in this. So if you have pain also and you're interested in a support group, my group is free. We meet virtually the second Friday of every month from 11 to 12:30. You can easily send me an email. It's just cindy@uspainfoundation.org. I see it's not terribly readable here, but maybe I can put it in the chat later. And then also, if you want to learn more about our federal bill, I am doing a free webinar on that for the U.S. Pain Foundation. If you sign up on the U.S. Pain Foundation's website, you'll get an announcement about it, and basically make it very easy for people to take action and be an advocate for it. You can also volunteer for the U.S. Pain Foundation or for the Mass Policy Initiative. I'm going to stop here. Thanks for listening. I understand we're going to take questions in the end. And next, I'm going to turn to Jackie Nathan, who is a nurse practitioner I work closely with. She is on the MassPI Steering Council, and you heard a little bit about her bio in the beginning. So, Jackie.
Thank you, Cindy. Can everybody hear me? You're all on mute, so probably, hopefully, you'll let me know if you can. Anyway, thank you for inviting me today. My talk is going to be on pain neuroscience, which is a fancy word for that means we're going to talk about the nervous system as it relates to pain. I've been studying this for over a decade because it's absolutely fascinating to me, and maybe by the end of the talk, it'll be at least a little bit fascinating to you as well. But this is a very complex topic, So I'm going to try to make it as simple as I can. Let's start with why we even have a nervous system. Whoop, I'm in charge of doing the slides, so let me do that. There we go. We have a nervous system to protect us. A nervous system is involved in the operation of everything in our body. Its job is to keep the tissues of our bodies healthy and functioning properly. If tissues are not healthy and we're not healthy, then the job of the nervous system is to keep obviously the job of the nervous system is to keep us in the gene pool. There are two components we're going to talk about today, the peripheral nervous system. You may remember this from high school biology, but it's the part of the nervous system that starts at the spinal cord and branches out to every area of the body. There are actually 7 trillion nerves in the human body, so that covers a lot of area. In the peripheral nervous system, there are special nerves, and they are there to detect any danger in nearby tissues. And if the danger is threatening enough, they send this information in the form of an electric signal to the central nervous system. For this talk, I'm going to call these special nerves governors. And the reason I'm going to call them that is because their job is actually to govern the tissues around them. It's important to note that these special nerves can only detect 3 types of threats. One is mechanical forces. That's when you have an injury to tissues that's done by force. So it can be a laceration, a crush, any kind of sprains or strains or fractures. The second kind of danger that these nerves can detect is thermal changes. That's when there's a change in temperature, either inside the body or outside the body. So that if you had a fever, those nerves would be able to detect that. And the reason for this is because we need to let the brain know that there's a change in the peripheral parts of your body, and the brain then has to do something to make this system corrected so you can stay again in the gene pool. There's also chemical changes that these nerves can detect, and the chemical changes can be inside the body again or outside the body, though we have lots of chemicals in our body that regulate everything, and we need them all working properly and in the right levels. Notice that these special nerves, as I call governors, do not detect pain. The experience of pain can't happen without the other parts of the nervous system. Also, I'm going to tell you the nervous system is not a democratic institution. Governors have a lot of responsibility, but very little power. So let's move on to the central nervous system. I'm going to call this the gatekeeper for the part that's the spinal cord. The spinal cord receives messages from the peripheral, from those governors, and if certain conditions are met, it will relay them onto the brain. But it doesn't always relay them onto the brain. There's only certain conditions. It's very complex, but we'll leave it at that. The brain part of the central nervous system, I started with president, thought that would be a good word for it, but then I went to king, and queen I like better for obvious reasons. And then I decided it is so powerful, we're going to call it the emperor. So let's go through an actual pain scenario. So this is Fred Flintstone, and he just dropped a bowling ball, which is a rock, on his foot. Now, most people would think they would just simple bowling ball in the foot equals pain. But in fact, a massive amount of chemical and electrical things happen before Fred will ever have an experience of pain. Remember those special nerves that I called governors as part of the periphery. Their job is to detect threats to the tissues. The governors in Fred's foot just detected danger. The tissues in his foot just got crushed. That's a huge threat and potentially dangerous to his health and maybe even his life. So the governors send danger messages related to that injury to the gatekeeper. And okay, let's say in this case, because I said sometimes the gatekeeper in the spinal cord doesn't send that message on. But in this case, let's say in Fred's case that the gatekeeper actually relays this message onto the emperor, again, which is the brain. It's up to the emperor to decide whether to create a painful experience or not, and how much pain the situation requires, all in order to get Fred's attention, to keep him safe, and it needs a lot more information to make an appropriate decision. First of all, it needs to know a lot about the environment, like the location. What's happening around Fred? Is there more present danger for him or someone else? If Barney in that picture, you might remember he had like a frightful look on him. Maybe it's because He just saw a woolly mammoth that's charging towards them at that very minute. What's a bigger threat to Fred's safety, Fred's toes or the woolly mammoth? This kind of scenario actually happens all the time. For instance, there are many battlefield stories, many stories of soldiers in the heat of battle who discover they were actually hit by a bullet, but they didn't even know it. In fact, there was one of the last remaining World War II vets recently who had an MRI done and they found a bullet in his neck and it was just an incidental finding. Turned out he was shot during World War II. He didn't know because the brain is very smart and it made a calculation that creating pain at that moment would likely lead to his death, and getting out of the dangerous situation is more important. Here's another example that might be more relevant to you. Let's say you close one of your fingers in your car door. That's extremely painful. We have a lot of sensors in our fingers for good reason. But understandably, in that moment of extreme pain, you take your eyes off your toddler and he runs into the parking lot. Would it be advantageous for your brain to create pain in this situation? No, because you would need to save your child. And this happens in all kinds of situations like that, where your brain does not create pain at that moment until everything is safe, and then you will experience the experience of pain. And here's an example for Fred. Maybe the tournament was on the line and Fred's next bowl was going to be super important to winning. And this happens all the time in sporting events where athletes will have a pretty bad injury, for instance, a fracture in their leg, yet they continue to play out the point or the game or even part of the period or match until they get off, because it was more important at that point in terms of the brain made a calculation. The brain also relies on context. So in Fred's case, has this ever happened before? How important are Fred's feet? Maybe Fred has had this injury before. And at this moment, he's actually thinking, oh my God, the injury is going to ruin my life. It's going to cause me financial hardship and maybe even end my marriage to Wilma. It turns out thoughts are messages too. With repeated thoughts of doom, the emperor, in Fred's case, is going to get the message that this situation is very dangerous and create a very painful experience. To illustrate how context can influence the decision-making process, we know from studies that the same mild hand injury causes more pain in a professional violinist than a professional dancer. Why? Because the hands in a violinist are much more important. Here's another example. If you suffer from a neck injury from a car accident, it will hurt less if the accident was your fault than if someone else caused the accident. So the emperor consults with hundreds of brain regions, including the thinking parts and the memory parts, and its job is to conclude, based on credible evidence, whether or not to create pain. This happens in milliseconds and is that pain is all in your head. Maybe it's correct because it's really coming from your brain, but they actually really don't understand the nervous system. So in this slide, you can see there's a bunch of regions of the brain. They all have little tags on them. And those blue lines are the nerves that are connecting them all together. We call this a neurotag or a neurosignature. And it's actually the nerves in the brain connecting to many parts of the brain in order to have an experience of pain or anything, actually. And I'll get to that in a minute. So how often have you had pain and how severe it is? Depends on how often this pain neurotag connects and the strength of the connection. It turns out memories are neurotags also. The sequence of how to brush your teeth or ride a bike are neurotags. Negative thoughts become neurotags too. Often the emperor will involve other systems to help keep us safe. So it depends on the level and the kind of danger. But one way they could give us pain, and sometimes we do have that, but other times there are other things that get involved. So if we get the experience of pain, It's to motivate us to escape or seek help or attract attention. Sometimes the sympathetic nervous system is activated by the brain, and that is to increase our heart rate, mobilize energy stores, increase our vigilance so we can pay attention to keep us safe. Or it could be engaging our motor system so we can run away, fight, protect damaged areas. Or oftentimes our immune system is activated, and that's to promote healing, fight invaders, or sensitize neurons. And lastly, it could engage our endocrine system, and that would be to mobilize energy stores, reduce gut and reproductive activity, because we don't need those in times of extreme danger. Let's talk about persistent pain. Well, the system I just talked about actually works whether the pain is acute or chronic. But in a persistent pain state, there is no longer an imminent threat to the tissues, or maybe there was never a threat in the first place. So why would the brain continue to create pain? The simple answer is that with enough repeated incoming messages, the nervous system adapts. The nervous system adapts because it can and does all the time. We call this neuroplasticity. This is important because this is how acute pain becomes chronic. We know now how this happens. So nerve cells and the gatekeeper, which is the spinal cord, get better at sending danger messages to the brain. They get more adept at it. The nerve cells become more sensitive. Their receptors, that's where they receive the information from the periphery, they stay open longer, and they can increase the manufacture of new governors or those new danger detector cells. That means that more information is being flooded into the central nervous system. The nervous system is able to relay that to the brain and get better at it. And this leads to states of hyperalgesia, which is when a painful stimulus actually is more painful than it should be, or allodynia, when a non-painful stimulus actually feels painful. And that would be like brushing your skin. The emperor gets better at forming neural connections. That also happens too. And we have a sentence we use, but I wrote it wrong here, which is why I'm getting tripped up. It's actually neurons that wire together, fire together. And the reason I showed you that little picture of the brain with all those little parts that connect with the nerves, I called them neurotags. That's their scientific name. Well, they get stronger. They connect faster and they fire more often. So that's why you have a state of continuous pain, because these neurotags get very strong. So it turns out in a persistent pain state, the messages are no longer reflective of an accurate state of the tissues. The scientific name for this is called sensitization. And you can think of it as a nervous system on a high alert state. It's important to note that if you have persistent pain, it is neuroplasticity that got you into it. That's because the nervous system had to adapt. It's never your fault and never, ever under your control. It's more important to know that neuroplasticity can also get you out of pain. Let's talk about what you came here for, which is MUCFS. So the governors in the nervous system of people with this illness are alerted to threat, usually a virus, and that those governors will send messages to the gatekeeper. The gatekeeper may relay those messages to the emperor. Remember, I said sometimes they do, sometimes they don't. This is determined highly by genetics, gender, age, and culture. Not highly, but definitely play a role. The emperor weighs that evidence from incoming messages and from brain regions. Remember, thoughts are messages too. And it decides what response is most helpful. With time, the nervous system adapts with repeated danger messages. More governors are created. Neurotags are formed in the brain and strengthened. And then other systems get involved because you need protection from more than just pain. So you might have an activated immune system, which creates low-grade chronic inflammation. And you may have an activated endocrine system. Over time, you will have an increase in stress hormones or like cortisol. And this can lead to actually a chronic state of stress can lead to adrenal fatigue. And those symptoms can include tiredness, trouble falling asleep at night or waking up in the morning, salt and sugar craving, and needing stimulants like caffeine to get through the day. Understanding how the nervous system works is important because education is power. Once you understand pain, you can begin to understand what you can do to influence the brain's decision. you have power too. In fact, you have a lot more power than you likely realize. So I'm going to finish up with just some helpful resources. These are videos that I think are very helpful. The videos are help you understand how pain works. These are from Lorimer Moseley. And if you look up Lorimer Moseley on YouTube, you will find these two videos. They're my favorite. They're a lot, but Body and Mind, the Role of the Brain in Chronic Pain, and Pain, Brain, and Your Amazing Protectometer. I also have some book resources, also by Lorimer Moseley. The first two, Explain Pain. And that both these books you can find on Amazon. Explain Pain is understandable, but very detailed, and it's a pretty hefty book. That's pretty expensive actually, but the Explain Pain Handbook, which is what I use in my class with my students who have pain, that's a lot cheaper. It's about $37 on Amazon, and it is very helpful in understanding pain, and not only understanding pain, but actually helping you to understand what you could do actually to influence it. And lastly, The Way Out by Alan Gordon. Many of you may have seen this book. It is excellent at explaining pain and also explaining what you can do to help. Lastly, one of my favorite apps, one of my favorite all-time things is Curable. The Curable is about $5.99 a month right now, and it is immensely helpful. It has a vast amount of resources. I'll show you a couple slides of screenshots I took. So on the first one is a bunch of workshops that they offer. You can see how inclusive of everything: disarming your danger system, breaking out of chronic pain, reclaiming your identity, moving past the past. They have expert interviews, so you can just get some education from a lot of different specialists in all kinds of fields. This one says Recovery Stories. I included this one because it's actually a story on ME/CFS. And then they have way more than I put up here, but they have this thing where you can click on if you're in pain right at that moment. It says if you're in pain right now, that's okay. Recovery is not a straight line. Before we dive into any exercises, pause and take a few deep breaths, and then it'll walk you through some stress management to help you get out of pain. But there's also, they do meditation. They have meditation exercises. They have therapeutic writing. It's just an immense amount of resources. Again, thank you for having me speak. Oh, I forgot one more thing. I know a lot about scrambler therapy. Maybe some of you have tried that treatment. Unfortunately, it's a little bit expensive, but it does work really well for things like fibromyalgia. I've seen it actually in several different places around the country, and a big fan of that, and lots of success in that type of painful state. So that's all I have, and I'm going to pass the baton on to Michelle.
Thanks so much, Jackie. Good afternoon, everyone. Thanks so much for having me. My name is Michele Matthews. I'm a professor of pharmacy practice at Massachusetts College of Pharmacy and Health Sciences. I work out of the School of Pharmacy, Boston. I've been an educator for 20 plus years. I've also been practicing in pain management specifically for about 15 of those years. And then for the past couple of years, I've started working more with patients with substance use disorders. I know we're all aware that we're currently dealing with an opioid overdose crisis, but also the rise in substance use related to other substances as well. So definitely a need. I have a very non-traditional role as a pharmacist. I think, there's many times misconceptions about my profession and sort of what we do, the role that we play, and how we're educated. So I'm going to talk a little bit about what I do, and then also talk about some of the leadership roles that I've served in as well. I've been really fortunate to have a lot of firsts in my career. First being one of the first pharmacists in Massachusetts to specialize in pain management. Also, about 12 years ago, I worked with Brigham and Women's Hospital to develop what I call a collaborative practice agreement, which allowed pharmacists to have credentialing and privileging similar to a nurse practitioner or a physician's assistant. So I work very closely with our physicians at the hospital initially in the pain management clinic there, but also within a large primary care clinic, because that's where one of the needs was in terms of supporting PCPs and managing patients with chronic pain. And by putting these collaborative practice agreements allowed me to be able to prescribe medication, to refer patients for non-drug therapies, to order labs and monitor them, and really kind of serve as an advanced practice provider that was sort of complementing the work that the physicians were doing in those practices. And I'm still doing that to this day, in addition to also working with those patients with substance use disorders. I also do a lot of research. I've been really privileged to work as part of a team, not only at Brigham and Women's Hospital, but also at UMass Medical Center early on in my career. And really have been dedicated towards improving interprofessional pain management. So working with a team of other professionals to get out there and educate other healthcare professionals that are also working as a team, so that we can all provide more individualized, comprehensive pain care to patients. And have been fortunate to have funding from government agencies. I know Cindy said that the NIH has about less than 2% of their budget on pain-related research. I've been fortunate to get a little piece of that pie. And I also feel really strongly in advocacy. So part of my job as a clinician and educator is to advocate for my patients, but also as a pharmacist who was sort of one of the first in the Northeast to really be practicing in this area, had developed an organization as a founding member, which is called the Society of Pain and Palliative Care Pharmacists, and served as president of that organization 2 years ago, and have been involved in a lot of other pain-related interest groups within other professional pharmacy organizations, and have found my way to MassPI, which I currently serve on their steering council as a member at large. So I want to reference something Cindy had said. I feel like the sequence for our presentations today was perfect, and I know there was a lot of thought that was put into that. So Cindy had said that she was part of a task force back in 2019 that had released a report on best practices for pain management, and that's actually a report that I cite with my patients, with my students, but also in many professional presentations that I do as well. And I'm going to focus today specifically on medications, which the term you're seeing here is pharmacotherapy. But there's lots of other treatments that go into a pain management plan. And I think both of our speakers did a great job of talking about how it's really usually not just one thing that helps to manage pain, it's a combination of strategies. And I think when patients work with me for the first time and they hear that I'm a pharmacist, there's a lot of reservation that they express in terms of, well, I don't want to try new medications, or, you know, I've tried and failed a lot of things. I've had a lot of allergies, a lot of side effects, and I think I'm perceived initially maybe as a pill pusher, but I actually spend more of my time deprescribing or taking medications away, or in some cases just optimizing a care plan as it relates to a patient's medication regimen. So I want to talk today more so to provide you with information that helps you advocate for yourself, in the sense of when you're going to these appointments and meeting with healthcare professionals, what are some of the things that you can be doing to either ask questions or have a really good understanding based on a lot of the neuroscience that Jackie had talked about, in terms of, you know, where medications fit into that, you know, pain as a disease, but also how do they fit into me as an individual. So when we're thinking about starting medications for pain, we're always thinking initially about benefit versus risk. There's a lot of gaps in pain research, and especially as it relates to medications. And a lot of the studies often include a very small number of patients. But the other thing that we have to factor in, just like Jackie used this term neuroplasticity, is that everyone's makeup genetically is very different. So that means everyone's central nervous system may function differently as well. And then that translates into the fact that medications may not be one size fits all. So what that means is that a clinical trial that was done of a medication, even if it leads to the FDA labeling that medication as being indicated for pain or symptom management, doesn't necessarily mean that any of us are going to have that exact response to that medication. And there's a lot of factors that play into that. Like I said, it's genetics. Sometimes it's just the way our body metabolizes medications. It could be other medical conditions that we have or other medications that we take that could affect the response that we have to medication. So I think at the beginning and up front, it's really important. And this is the education I provide patients. This is what we're looking for. You know, we're looking for your pain to improve. We're looking for your function to get better. and we're really tying that to whatever goals that I'm working with the patient on. But I'm also realistic in kind of going through the list of risks. And we're talking about common side effects, serious side effects, but then also when we would potentially say that this medication is not a great fit for an individual. As I mentioned before, when it comes to labeled indications of medications, there are some medications within the United States that are indicated and labeled because they've been studied extensively for certain disease states, including different types of chronic pain syndrome. So they may have an indication for fibromyalgia, for chronic musculoskeletal pain, but there's also a lot of medications that we use, that some of which have been around for a really long time, that may technically be off-label or in some cases be experimental. And so I think it's also really important that you're aware that that may be the case. Some patients will ask me about that. Other times, in many cases, I will make sure that patients are aware that that's the case as well. Sometimes we repurpose older drugs for newer indications as we learn more about them, as they've been studied more extensively. And then sometimes we have an anecdotal experience. There's just experience that we have as clinicians where we've learned to sort of start to approach pain in different ways as the understanding of the mechanisms that fit into how pain is experienced from individual to individual, that may help with guiding our decision making. The other thing too is I kind of mentioned both of these things. The response is not one size fits all, but also that a lot of the times we're directing treatment towards goals. When it comes to medications for heart diseases or even diabetes, a lot of the times we're able to say, well, we want the blood pressure to get down to this number, or we want your A1C or your blood sugar level to get down to this number. We don't really have that with pain. Some patients will tell me, well, if I can get my pain on that scale of 0 to 10 to a 4 out of 10, which we would consider to be moderate pain, that they could be comfortable, that they feel like they could go out and do certain types of activities. So we try to make our goals as specific as possible. I like to use the SMART acronym. So we want the goals to be specific, measurable, achievable, relevant, and time bound, so that we can make sure that as we initiate treatment, we're going back to those goals and saying, how far have we gotten? What are the short-term goals? What are the long-term goals? And then the other piece that I think, and probably one of the more important pieces that I emphasize, is that medications are only a part of a comprehensive treatment plan. Jackie talked about some non-drug therapies. Cindy mentioned all the different treatments that she's tried herself as an individual. So I think it's really important that patients understand that. And I think some of the challenges that I've experienced in my practice is that many patients will come to me after they've tried and failed many interventions. And it's hard for patients to hear me say that, well, not saying that we're going to go back and try those things again, but we can't really put all of our eggs in the medication basket, because we've learned over time when that happens, patients tend to need higher and higher doses of medications. They may develop tolerance to certain medications, and that can lead to a lot of side effects and consequences as well. So these are just some things to think about, that you may want to have kind of in the back of your mind when you're meeting with a healthcare provider that may be talking with you about your pain, in terms of what medications are potentially out there based on your pain, based on the symptoms that you're having. Are those medications usually used for this type of indication, or is this something that we're using off-label? What should I expect from this medication? If a provider is not asking you about your goals, I think it's important that you bring up that as part of your conversation to say, these are the things I'm looking to be able to do. And then also acknowledging that by starting a new medication, it is not going to be the only approach that will be taken. It will be to complement and supplement other aspects of a comprehensive treatment plan. So I covered some of this already, but I think it's really important to take the initiative yourself to ask questions. I had a patient that was referred to me last week that I am seeing for the first time, and she's someone that had been working with a pain clinic for many years. She came in, said that certain medications weren't working for her. As a pharmacist, my brain immediately goes, well, let's talk about how you're taking those medications. And I learned very quickly that she was not taking the medications correctly. And what turned out to be what I initially thought was going to be a very complicated case in terms of what next steps we're going to take in terms of her treatment plan, it was, let's talk about all these medications, how they differ from each other. And then by having that patient sort of tell me the way that she's currently taking the medications, it really opened up an opportunity for me to explain to her the importance of which medications need to be taken on schedule versus those that you really should be taking as needed. And I think it was really eye-opening for her. But I also think, not to take away from the work that the pain clinic had done with her, but I think sometimes assumptions are made. I also think reflexively, patients sometimes will say, well, you're the boss, you're the doctor, so you're the one that is the expert here. So if you're telling me this is a medication I should take, I'm going to take it. But there may not be either an opportunity or in sometimes time that a provider can spend with you. So I think sometimes if you're able to go in there with kind of a list of questions when you think there may be an opportunity for changes in your treatment plan to take place, that you can have those questions ready to go so you can understand why that medication is being recommended to you, learn how to take it, what to expect from it, and then also understand how to follow up and when to call. And I'll cover some of those things when we talk about monitoring the medications after they're started. In the time that I have, it would be unrealistic to do a whole lecture on medications for pain. So I just really wanted to highlight a lot of the medications that we see pretty often in practice, and talk a little bit about where they fit in, and then also the best way to take them. So I'll start with acetaminophen. You may know it well as Tylenol. It's probably one of the more commonly used medications for pain. It's not always the most effective medication. There's some evidence to say that for patients with chronic pain, it may not be very effective, but in practice, we see a mix of patients' response to it. Oftentimes for chronic pain, we're seeing higher doses that are needed, and it's usually used for what we call musculoskeletal pain. So this is pain that's related to the muscles, the joints, and generally could be a medication that you take on schedule or as needed, but we do have to monitor certain things for patients that take a high dose for a long period of time, including liver function. Another class that we see commonly are anticonvulsants or antiepileptics. These are medications like Neurontin, Lyrica. You may have heard of those medications, both of which are used for conditions like fibromyalgia, also nerve pain or neuropathic pain. And Jackie talked a lot about pain neuroscience and a lot of the changes that occur in the central nervous system. And those things happen in the setting of seizures, but it happens a little bit differently when patients have chronic pain. And that's why we use the mechanisms of these medications and translate that over into how we manage chronic pain, because really what they do is they turn down the volume in the central nervous system and they reduce a lot of what we call that excitability that's happening in the central nervous system. And that's why it's really important that when medications like this are taken for chronic pain, that they're taken on schedule, because that's how they work best. So this is not a medication or a class of medication that really should be taken as needed. It could potentially be unsafe to do that because these medications can cause a lot of sedation. The next class of medications that we often use are antidepressants. So this could be medications like Elavil or amitriptyline, which is known as a tricyclic antidepressant, or Cymbalta or duloxetine, which is a serotonin norepinephrine reuptake inhibitor. And basically what these medications do is they keep certain important neurochemicals in the brain around to help with modulating pain. So they increase levels of serotonin, they increase levels of norepinephrine, and those are basically the same mechanisms that are used in managing depression, but there's overlap in managing with chronic pain. And antidepressants can actually be effective for managing pain, whether or not you have a history of depression or anxiety, because of the way they're working within the pain pathways. These medications have different indications. I'll use Cymbalta as an example. It's FDA approved for fibromyalgia, chronic musculoskeletal pain, so that could be chronic pain related to osteoarthritis, also effective for neuropathic pain as well. And similar to the anticonvulsants, this class of medication should be taken on schedule. So that means once a day or twice a day, however indicated, on a regular basis. For both of these classes of medications, because they need to be taken every day on schedule for them to be effective over time, and they may take a few weeks for them to get to a point that a patient notices a change in their pain, it's important if a decision's made to stop either of these classes of medications, that these drugs have to be tapered. My rule of thumb is that anytime a medication is working within the brain and you're taking it on a daily basis, you cannot just stop it because there's a risk of going through withdrawal. And withdrawal could be really uncomfortable. There are some medications and substances where withdrawal could potentially lead to something very serious. But in the cases of these medications, as long as they're tapered, generally we don't see withdrawal issues related to coming off of these medications. The next class of medications are muscle relaxers. These are medications like Flexeril, Baclofen, Tizanidine, very effective for muscle pain and or spasms. So we have a lot of patients with chronic low back pain that have spasms, patients with multiple sclerosis who develop spasticity and spasms as well. In general, we recommend that these medications be taken as needed because this is a class of medications that you could develop what we call a tolerance to. That means that the medication becomes less effective over time, resulting in a need for a higher dose. These medications also work in the brain, so they also can cause some sedation. And by not taking it on a scheduled basis and as needed, you can sort of preserve the effectiveness that you can get from these medications. And generally, we don't really have a lot of evidence to suggest that they're ideal medications to be taken chronically every day for a long period of time. Another class are the anti-inflammatory drugs. So we have our NSAIDs, which are non-steroidal anti-inflammatory drugs like ibuprofen or Advil, naproxen or Aleve. And then we have steroids like prednisone. These medications are very good for musculoskeletal pain and inflammation. And it really depends on the clinical indication on whether or not it would be appropriate to take these on schedule or as needed. And then the last class I'm just going to mention are the topical agents. So these are drugs that are applied directly to the skin, like a lidocaine patch, capsaicin, or even diclofenac, which is Voltaren gel, which I know is available over the counter. These medications are really good for localized pain, where lidocaine can be helpful for nerve pain, capsaicin can be helpful for nerve pain and or arthritis-related pain, and then Voltaren gel or diclofenac is effective for arthritis pain. And similar to some of the other classes, it's generally based on indication on whether or not it would be appropriate to use these regularly or as needed. So if any of these medications, and I know I didn't cover all the medications, there's a lot of other things that are out there, things that are more experimental. I'm not mentioning opioids here because I think in general, we're often reserving those for specific clinical situations. I know they're still a very important tool, but in terms of some of the pain that you may yourselves be experiencing, I think a lot of these medications can also be targeted to those symptoms as well. So once these medications are started, in terms of monitoring them, we're looking for understanding the common versus serious side effects. So some common side effects are self-limiting. They may happen early on in treatment. I had mentioned sedation for a couple of these medications, which is not uncommon based on how these medications work and where they work. They're working in the central nervous system. They're often sort of causing a depression of some of the activity in the central nervous system. So we often suspect that sedation will happen. But by continuing to take these medications every day, it would not be surprising to see that that side effect starts to go away. There are some medications that can cause constipation, but if the medication is very beneficial and it's producing the results that we're looking for, then it would be appropriate to potentially treat through that constipation. And then also understanding what the serious side effects are and when to report those and when to seek medical attention. Jackie had mentioned the Curable app. The Curable app is something I actually use to have my patients track their response to different changes in the treatment plan and how that impacts their pain and function. Curable, you can actually ask your healthcare professional to enroll into the site, and they can send you a 6-week free trial before you have to actually start paying for the app. I think that's a really great way for patients to get used to it, understand how it could potentially be beneficial for them, and then also for us to have some information that we can refer back to at follow-up visits. I also go through how to store and dispose of medications safely. Some of the medications we use for pain may be dangerous to children, to pets. Also, some of them may be controlled substances, so it's really important that they're stored away and in some cases locked away. And then with disposing medications, most pharmacies have disposal bins now. You can also go onto the DEA website and search your zip code so you can find locations to drop off medications in a safe way. There's also the National Drug Take Back Day that I think is hosted at least now twice a year by the DEA. And then lastly, when to talk to your provider about reconsidering treatment. And this gets back to the goals that I had talked about earlier. It's really important that we're reflecting on those when medications are started, so we can say at some point, yes, this is something that makes sense to consider to continue, versus when we might have to taper, stop, change to something else. So always feel comfortable bringing that up to your provider to say, hey, I've been on this medication for a couple of months. I'm not really sure that it's making a difference. And then by backing away from it, sometimes slowly, we can better understand what role that medication was playing. And if it wasn't doing much, then that would be something to stop taking. Another thing I want to mention, because cost of treatment continues to increase, I just wanted to provide some tips for reducing medication costs that I think could potentially be helpful. So streamlining medication use, I used the term deprescribing earlier. So this is where we start taking some medications away. Sometimes medications are started during a hospitalization and then are continued once you're out of the hospital. May not really be clear why that's happening. So really having someone on your healthcare team really evaluate all of your medications, what you're taking them for, and looking for opportunities to take things away and optimize them. Tablet splitting is another. A lot of tablets can be cut in half, so you can work with your provider to prescribe maybe a higher dose that could be cut in half so that quantity lasts a little bit longer. A lot of insurances may require 90 days supplies. You may have a preference for that too, because larger quantities may result in a lower copayment. There are samples and copay coupons that can happen. This may not apply to all medications that are used for pain management, but just something to consider is that these things may provide upfront savings, but they may eventually cost more in the long run. And copay coupons cannot be used with government-based insurance. So there are some restrictions there. There are discount and savings cards. So I think you're probably all familiar with things like GoodRx that could potentially be used as an alternative to insurance. A lot of challenges with utilizing them. It sometimes kind of forces you to go to a specific pharmacy as well. So they're not perfect. There's also some online pharmacies, Amazon Pharmacy and a couple of others that are generally offering more discounted prices because of the way that they're negotiating directly with pharmaceutical manufacturers. And then for people that have a very limited income, most of the drug companies offer assistance programs where you can go directly to them, apply, and if you meet certain income standards and cutoffs, generally they're able to offer that medication to you at low to no cost. And I also wanted to just end with some additional patient resources. So Daily Med is a website that references almost every medication that's available within the United States. You can just type the name of the drug in there and it will link you to a lot of really important and accurate information about that medication. There's also a great safe dosing guide that was put out by the US Pain Foundation, which I know Cindy is very involved with, that I hope you would find helpful. There's also the Stanford Guide, which is available on the American Chronic Pain Association website, that is updated pretty regularly. I can't account for the accuracy in that, but it covers almost all the different types of treatment options that are out there, and kind of covers pros and cons as well. And then the International Association for the Study of Pain has a section on living with pain resources that I think would be helpful as well. And with that, I'm going to end, and I see we have some questions that are popping up, and I'll turn it back over to our hosts.
Thank you, all three of you, for your wonderful presentations. It was really an honor to hear all of your words and your individual practice, and the approach that you guys take to pain advocacy and treatment is really so important. I'm going to take some questions from the audience. We are after 5, so I'll probably do just a few. But as a kickoff question that I'll start with, I know each of you are speaking as individuals today, but if any one of you want to tackle this question of telling us more about the Mass Pain Initiative as an organization and really what you do with patients or for patients.
So I guess I can start. MassPI is largely an organization for healthcare professionals that treat people living with pain. And so it's not necessarily, it's not really an organization for treating individuals with pain or for support groups, that kind of thing. We do education. So we do have one conference, at the fall conference. Anyone can come to that, but healthcare professionals get CEUs for it. And then we do policy. Like I said, I have policy council, and individuals with pain can volunteer for that. The organization itself, though, is largely interdisciplinary healthcare providers. So different than, for example, the U.S. Pain Foundation that I work with, which is Michele mentioned, which is a patient organization. We have about 35,000 patients that are members. People can sign up, and there's many free resources like a newsletter, webinars, lots of other information for people living with pain.
That's definitely helpful for our audience members to know. And we're going to put some of the additional, obviously this will be in the recording, but in the chat as well, we can put some of those shared links. Cindy, another question directly for you. Do you have any advice as us as an organization seek state policies to cover ME/CFS?
Yeah, actually, I mean, I think it's important to engage with your lawmakers and educate them more about ME/CFS, how many people are affected in Massachusetts, and what you're seeking in terms of better care. The Massachusetts legislature has a 2-year session, and the current session is ending July 31st, but we'll start again in January. So the fall might be a good time to get to know some of your lawmakers and talk about some policies you'd like to improve. And then think about perhaps asking some of them to sponsor bills that get introduced in January. So that's kind of, the way we work with the legislature. And I think it's really important to know your own lawmakers and educate them.
We will take that advice strongly. This one to the floor for any of you. In your collective experience, what % of patients in the pain clinic experience some improvement in quality of life, would you say?
I mean, I guess I can start. So one of the tools that I utilize is it's called the PEG score. It's actually very patient friendly language where we're using a scale of 0 to 10, asking about average pain severity over the past week or so, but then also how pain interferes with general activity and enjoyment of life. So I would say that we're often seeing those numbers, and Cindy did a great job of explaining kind of the roller coaster of pain. Patients getting better is not linear. So there are times, I see patients mostly every month, and there are months where they're in a great place and life is good. And then the next month, all hell has broken loose. So I think it's just really important that even though we're putting numbers to this, that we're really understanding why patients are rating, this time I'm seeing them a 9 out of 10, whereas the last visit was a 4 out of 10. So yes, the improvement can be there, but I think it's a matter of like how patients are defining what that enjoyment of life / quality of life is for them. And that's why setting those goals early on when we're first meeting with patients is so important, so that we can really better understand that, because there are some patients and also some patients with certain disease states that will chronically report high pain scores, regardless of the fact that they are actually getting better over time. And that's where the numbers and really focusing on just the numbers can become very tricky and challenging.
That makes a lot of sense. And I'm sure a lot of patients will resonate with what you were saying, Cindy, as a patient, kind of the roller coaster of different treatments and kind of the approach. So that makes a lot of sense if it's not a clear-cut answer. One of our other important questions, how can people find a pain clinic? Where should they go?
Jackie, you want to take that one?
Well, I think it's becoming more difficult. Well, I don't think, I know, because there are just fewer available and fewer providers who want to do anything in terms of sitting down with a patient and doing what Michele does. Because the money that's generated from pain clinics is mostly through interventional therapies. And a lot of pain clinics just solely focus on that. And so it leaves a lot of people out, to try to figure things on their own because there's just not enough providers. I've actually retired, but when I was working as a pain management provider, I worked in a primary care office of about 80 primary care providers. It was a great system, I thought, because primary care providers, although they were kind and lovely people, they have so many other problems to work on that they just really didn't have either the time or the expertise to have help people with pain. And so I actually provided that piece for them. We had a lot of other specialties too, so it worked really well. And anyone with any kind of persistent pain would see me, and I worked just like Michele did. So
Yeah, and I don't think there's a repository that I'm aware of that patients can go to. So I often tell patients to check with their insurance provider first to see what's covered and then do their own research and really understand what those clinics offer, see if there's, any way that they can sort of understand what to expect from those clinics. And it is there's almost an interview process that has to happen. I mean, Cindy has probably the best experience to kind of reflect on here, where it took you 5 years, right, to find someone, and that's not uncommon for us to hear. So, we talk about this revolving door of pain care, that it's, by the time patients are coming to my clinic to be seen, they may have gone through 3 or 4 different pain clinics.
I know many of our viewers are from Massachusetts, but not all. So hopefully someone can maybe start at that insurance and kind of follow from there. One of our specific questions from the audience, I know, Michele, you covered some specific pain medications, but this person had asked for Neurontin, if I'm saying it correctly.
Yep.
The reservation for that, taking it as needed, is it a concern of sedation really, or something else that it doesn't work as well if not taken as needed?
Yeah, so and I do see it used and recommended to be taken as needed, but more so for management of other symptoms, not pain specifically. So it could be taken as a single dose at bedtime. I've seen psychiatrists and some specialists recommend it as needed at bedtime or as needed for anxiety. So for sleep and anxiety, I think we have to just be really careful, because that is like very off-label, and really someone, as a specialist that has a lot of comfort level with that medication and giving a patient clear instructions on how to take that. But in the moment of it being used as a single dose, it's really causing more relaxation and sedation, which might be helping with anxiety and other symptoms, not pain directly. It's not really getting to the underlying mechanism of pain by taking a single dose as needed.
That makes a lot of sense. I think we can take these last couple questions. One other specific one was if anyone in the group had thoughts about LDN as a therapy.
do you do that, Michele?
I do. Yeah. Yeah.
Go
I'm an
ahead.
advocate for it. I think that I've had a lot of patients that have done really well with it. I'd like to see it maybe used a little bit earlier on in the treatment plan, whereas oftentimes we're going to it as an option for patients that have tried and failed other medications. But, I should have clarified, low dose naltrexone. So naltrexone is an opioid blocker, right? So opioid agonists, basically something that sits on the opioid receptor and stimulates it, is what we typically think of as something that works as a pain reliever. So the question that comes up is, why would you use a blocker, something that blocks that receptor and prevents the receptor from doing what it's supposed to do? Well, the thought is that if we use it at a really low dose, and we have ultra low dosing, very low dosing, and low dosing of naltrexone, that it has a paradoxical effect as an analgesic, so a pain reliever, and also an anti-inflammatory medication, and may have other mechanisms within modulating the pain pathway as well. We often have to use a compounding pharmacy to get the doses that we need, because it's only commercially available as a 50 milligram tablet. When we use it for chronic pain, we're using micrograms, or 1 to 10 milligrams a day. And I've seen patients tolerate it really well. They take it once a day, usually in the morning. The one side effect that I've seen pretty commonly with it has been some disruption in sleep and like vivid nightmares, but patients take it in the morning, generally don't see a lot of side effects with it. And I've had a couple of patients who have had co-occurring inflammatory conditions like inflammatory bowel disease, who have had benefit both in that disease state because it works as an anti-inflammation medication, but also as a pain reliever for their chronic abdominal pain. But I've also had patients where it's done absolutely nothing. There was no benefit. So it really has been completely mixed. So Jackie, Cindy, I don't know if your experience has been the same.
Yeah, mixed. I mean, I think that's the case with most
Yeah.
medications, as you've often talked about. Everyone is so different. You really have to try it and see if it helps you.
I've had some success with it as well. but the limiting factors were always cost because of the cost of compounding, which wasn't covered by insurance. But when it works really well.
Yeah.
That actually segues nicely into what I think we can take as our last question. Someone from our group asked if you ever see patients with MCAS, mast cell activation syndrome, who can't tolerate medications that use the microcrystalline cellulose as a filler because of a trigger, and if in the future compounding pharmacy might be covered for these patients.
Yeah, I'm not aware of any legislature or movement to include coverage of compounding medications on insurance formularies. It would be lovely if that happened. But also there's some evidence to say that they're not always very effective and can be very costly. So I think we have to kind of be considerate of that too. I know that compounding pharmacies use different fillers, so that when I'm prescribing low dose naltrexone, I'm actually writing on the prescription to not use any fillers if they're able to do that. And the pharmacy will call me back if they say that they have certain protocols or certain things that they'll use, and I'll screen for that. I'm not aware of the microcrystalline cellulose specifically triggering MCAS, but I will certainly look into it, and happy to do some research and answer that question offline. But there's other things that compounding pharmacies put in their medications that I think some of us aren't even aware of. So sometimes it's helpful for patients and us as healthcare professionals to question that. I had a patient that was on a medication that we found out that they were adding ginger to the capsules, and it was almost a way for it to act as like an abuse deterrent. So that if someone opened the capsule and tried to, do something other than take it by mouth, that it would have caused them to have a uncomfortable reaction. And it was just not something that I had any idea was happening. So, and I'm not saying that that's common practice. I'm just saying in that one particular situation that the filler could potentially make a difference for some patients in terms of tolerability.
That's something that, yeah, I definitely would not have thought of, and really insightful from your practice. I think that's all of our questions for the Q&A today. So I want to thank all three of you again for your talk and for answering these. To our group, as a reminder, this recording of the session will be posted on the MassME YouTube channel as soon as we can, and you'll get an email when the recording is up. And of course, please feel free to share the video with your family and friends and on social media if you'd like. In closing, we'd like to share the exciting results of our 5K walk, run, roll that happened on June 8th at the Boston waterfront with our partner organization, the McCourt Foundation. So our team, MassME, showed an inspiring outcome, and despite the weather not being so cooperative with the rain and cooler temperatures, we ended up raising almost $14,000. So we really want to thank everyone who participated and donated, and here you can see some pictures from the event. We really look forward to another terrific event next year. In looking ahead, our next Sunday Conversation event is going to be in August, so no event for July, just as a reminder. It'll be again on the third Sunday of the month on August 18th at 4 p.m. Eastern Time, again with our wonderful Sarah Nesson, who's joined us in the past. She's going to present a new body of work. It's called Body of Water, and lead a community conversation. And finally, if you found this program worthwhile, there are a lot of ways you can help. You can make a donation to help support the series by donating online at this website below, massmecfs.org/donate. On that same page, you can sign up for the MassME newsletter, and along with a donation of $25 or more, if you check the option to become a member, that'll establish or renew your membership, and you'll be invited to our members only programs. So thank you all again for coming. To the members of the Mass Pain Initiative today, Cindy, Jackie, Michelle, thank you so much, and we hope to see you all again next month. So take care, everyone.